Alright guys, this is the second lecture. We're going to be covering spirograms, flow volume loops, FEV1 over FVC ratio, and obstructive versus restrictive lung disease. And when you see the spirogram, you're going to see a category of terms called volumes and then capacities. And volumes are just lung volumes, and then capacities, all they are is a measure of two or more lung volumes. That'll be more clear in the next slide. Or sorry, the slide after this. This is just a review from the previous lecture because I was a little confused by the term respiratory epithelium down here in this picture, and all the Googling did was confuse me more, but I think the term respiratory epithelium is usually meant to refer to pseudostratified ciliated columnar, pseudostratified ciliated columnar epithelium with goblet cells. Now, in this case, in the case of the respiratory bronchioles, there are no longer goblet cells. So in this case, it would be like ciliated cuboidal or ciliated columnar. That might be a Dr. Meek question. I might check with him on that. But these are just good histology pictures. I'm sure you guys can identify a goblet cell, the cilia, basal cells. Basal cells are kind of like the regenerative layer. And in pathologies, like especially chronic bronchitis, when there's smoke irritation, you see goblet cell hyperplasia and basal cell hyperplasia. And let's see what else. Also something, I'd have to double check this because it's purely from memory, but I think smoking can cause squamous metaplasia, so it can cause the respiratory epithelium to actually change to squamous, because squamous epithelium are better equipped to handle the damage from smoke inhalation. So it's a good term to be familiar with, metaplasia, squamous metaplasia. Okay, so this is tidal volume from a spirogram. So every time it goes up, take a breath in. Every time it goes down, take a breath out. In, out, in, out. And this is Dr. Curtis's animation, so I got to give him credit here. And this is just normal breathing, not exerting yourself. This normal tidal volume. A lot of times this happens without us even thinking about it. And that's about 500 ml. Next, okay, take a big deep breath in. And the max inspiration is called inspiratory reserve volume. Now the two of these together make up inspiratory capacity. And then after you've taken this big breath in, when you exhale, as much as you can, that goes down to the expiratory reserve volume from here to here. And the terms are pretty intuitive, so I hope this clicks with you guys. The vital capacity is all three of these volumes added together. And the total lung capacity is the vital capacity plus the residual volume. And that's what's left in the lungs after maximum expiration. The functional residual capacity is made up of the ERV plus the RV. So the expiratory reserve volume plus the residual volume. This is a different way of seeing the spirogram. So this spirogram is like really important. I would recommend drawing it out on your test. Like as soon as you get your test, draw it out with each of these volumes. And that way, if you get some type of question that asks for a specific number, like what's the expiratory reserve volume, you don't have to memorize the equations. You can just draw it out, and then it all makes intuitive sense to do the math. And here are the actual definitions if you prefer to read instead of visualize. And a lot of these make intuitive sense, so definitely like practice drawing this out a couple times. These are the definitions of the lung capacities. Note when it says, it's kind of important to know residual volume cannot be measured with spirometry, and that's, you know, what produces the spirogram, which is what this is. And to measure the residual volume and any capacity that includes the residual volume, like the FRC, you have to do an additional test using like helium or nitrogen, like helium dilution test or nitrogen washout test, or I'm not sure the exact, something like that. And that's how you determine the residual volume. And then the capacities obviously are just inferred from the results of the volume measurements, because remember, capacities, all they are is just 2 or more lung volume measurements. We will, okay, so vital capacity, you will also see this as FVC, which is forced vital capacity, and that's really important. You'll see later on when we look at the FEV1 over FVC ratio. All FEV1 stands for is forced expiratory volume in 1 second, and then that's divided by the forced vital capacity. This is a flow volume loop, and I don't know why, but these are really important. You get lots of classic questions with these. I'll tell you what you need to know though for boards. To try to explain it, I circled 2 important capacities up here, and then the residual volume, so you can reference the spirogram. So in a flow volume loop, the lung volume is on the x-axis, but the zero is over here. Okay, so that's to keep in mind. Inspiration is anything under this horizontal line here. Expiration is anything over. So that kind of makes sense if you look at this normal blue line, right? Breathing in, as you're breathing in, the lung volume is increasing. And then you get back, or when you get, you know, maximum lung volume, you start expiration, and then as you expire, right, you're losing lung volume back to the starting point. So it kind of makes sense. The y-axis is something I always had trouble making sense of intuitively, but it's the flow rate in the liters per second. So I guess like how fast the air is moving in and out of the lungs is recorded on the y-axis. But if we compare to the spirogram, the residual volume is the air that's left in the lungs, remember, after a maximum inhalation and a maximum exhalation. So you can't really get it out if you tried. It's just there. So that makes sense that the residual volume in the flow volume loop would be from here to here, right? Because this is inhale, exhale. So it's the volume that's left after maximum exhalation. Now, the forced vital capacity makes up the the tidal volume, maximum inspiration volume, and then maximum expiration volume. So it makes sense then that in the flow volume loop, the FVC would be measured from here to here. And remember, I'm referencing this normal flow volume loop. So one thing you have to memorize is that obstructive diseases move the flow volume loop to the left, and restrictive diseases move it to the right. Obstructive diseases, I'll tell you this now and revisit it later on. So what they do to the spirogram here, they cause an increase in residual volume and an increase in total lung capacity. Now, when you increase the residual volume, makes sense that the total lung capacity would increase, but the residual volume increases so much in these cases that it actually crowds out the other volumes. So everything else decreases in obstructive lung diseases. What else? Okay, just for reference, that would be like asthma, bronchiectasis, chronic bronchitis, and emphysema. And these two are due to smoking. And obstructive lung disease means, just if you don't remember anything else, remember you can't get air out. Now, restrictive lung diseases, there's a bunch of restrictive lung diseases. Fibrosis is probably like one of the really common ones that you'll see. And so what they do, they do the opposite. They decrease the residual volume. So it kind of makes sense, right? On a flow volume loop, you can see the residual volume for restrictive lung disease is decreased compared to normal. And then for obstructive lung disease, it's increased. So we can go over that more in class later if you guys have questions on it. This is the FEV1 over FVC ratio, and all that's done here is you tell the patient to inhale as much as possible and then exhale as fast as they possibly can. It's called the forced expiration test. Normal is around 4/5, and these are, you measure it in, I forget, liters or milliliters, whatever. But anyway, the ratio is what's important. So our normal ratio is around 0.7 to 0.8. And restrictive lung disease, you might see something like 1/3, or I'm sorry, you'd see something like 3/3, and then obstructive lung disease, you might see something like 1/3. This is another explanation of the FEV1 over FVC ratio. This is very important. High yield. Here's a YouTube video further going into it, and this sums it up. So like in obstructive lung diseases, you cannot fully exhale. You have air trapping. And then restrictive lung disease is the opposite. You cannot fully inhale because there's fibrosis or something that's preventing you from taking a full breath. And I put in red here the most important things to pick these out of a question stem, but it's super, super helpful to be able to pick up in a question stem whether they're talking about obstructive or restrictive lung diseases. And they can ask you like a variety of things. There'll be some type of test question on this for sure. Let's see here. This is further explanation of the ratio, the FEV1 over FVC. So let's take a look here at normal. So normally you can get most of your expiration out in 1 second, right? So 7 to 3. So you can get 4 liters out, and then 7 to 2, 4 out of 5. So that means you can get around 80% of the volume in your lungs out in 1 second of your forced expiration test. Remember, in obstructive lung diseases, you cannot fully exhale. You have problem getting air out. And clinically, that results in, if you think about it from an anatomical perspective, you'll have, because of the air trapping, you'll have something called increased AP diameter. And AP is just like anterior posterior. So you might see the term like barrel chest. And that's literally because the lungs are holding so much air that they push your chest out anteriorly and posteriorly, so you have an increased AP diameter. You will also see low, I think it's like low diaphragms. Yeah, because your diaphragms go down when you inhale, and then if you can't exhale, you'll see the diaphragm drop when you do like x-rays or imaging. Anyway, this is a classic pattern for obstructive here. FEV1 is around, like in this case, I think it's like 2 over 4. So that ratio is 0.5, which is significantly less than the normal. In restrictive, sometimes all of the air will actually come out in 1 second. So in this case, it'll be around 3 over 3, and that ratio is 1, and that's greater than the normal ratio. So in physiology questions, specifically like respiratory physiology questions, you have to know different ways of looking at the same thing. So especially the USMLE loves giving you graphs that are upside down, backwards. The axes are different than you're used to looking at. So if you can just keep in mind the hallmark, the hallmark symptoms and the hallmark ratios for these diseases, you should be able to pick up in a graph like what's going on. And I included just different types of graphs so you get used to looking at comparing normal versus obstructive versus restrictive. This is a good explanation from first aid, so it's good to look at. Okay, which of the following is a normal FEV1 over FVC ratio? 4 over 5, around 0.8, and you might also see like 80%. Okay, you can also see that. B, so would that be more obstructive or restrictive? Be obstructive because it's less than the normal. Okay. Same thing with C, obstructive pattern, 2 over 4 is 0.5, so it's less than the normal. D would be restrictive pattern. It is greater than the normal. Which of the following is indicative of a restrictive pattern? FEV1 over FVC greater than 0.8. That's true. Decreased residual volume. That's true. C, increased residual volume. No, that would be obstructive. So remember, obstructive causes increase in residual volume and an increase in total lung capacity. So the answer is D, both A and B. And I'll go further into obstructive and restrictive lung diseases in class, because it's important to have a good understanding of that.